Good evening. Hello, good evening. Good evening. How are we doing today? How has your day been? Mine's been a long one. Busy, but I'm grateful to God. Good evening, everyone. Thank you for joining. Thank you for joining us. This evening we're talking about menopause, embracing menopause journey with confidence. So we're doing part 2 today because we talked about this a bit last 2 weeks, and so due to popular demand, a few more people wanted to know more stuff. So today we are doing the part 2 of embracing menopause journey with confidence. But quickly, before I start I see my guests. One person is here. 1 minute past 7. I was gonna give you a few minutes and let more people join, but I'm just gonna get cracking, honestly. And thank you everyone who's joined already, and looking forward to more people joining. But this evening I just wanted to bring a word to us that today jumped at me when someone that I know was sharing this word. So it's from the book of Psalms 67 verses 2 to 3, the Passion Translation. He says, so it's it was prayer that David prayed. He said, send us out all over the world so that everyone everywhere will discover your ways and know who you are and see your power to save. Let all the nations burst forth with praise. Let everyone everywhere love and enjoy you. And for me, that really jumped at me today. How this is supposed to be our heart cry now, as children of God, that we're asking that the Lord will send us out all over the world so that everyone everywhere will discover the Lord and the ways of the Lord and will see his power to save through us, through our lifestyles, through, how we engage and how we show the love of God to people. And that the nations, the people who encounter us, can burst forth with praise. And everyone, everywhere, through us, can experience the love and the joy that is in God. And that stayed with me today. Anyway, I thought I'll share that. I'm just going to let my guest in. Today we're talking about embracing menopause journey with confidence. Last week we were talking about some of the things that this menopause is. Oh, two of my should have Dr. Moji, and then we have Shola Taiwo. She's a advanced nurse practitioner. Yes, that's who she is. And so everyone today, they're going to be helping me talk about who's joined. We can't see you. What happened to your video?
To be honest, I've been on M25 for last 4
Oh,
hours. I can think.
I'm
Yeah, and I'm
sorry.
still not home, so it is in the car. That's why I can't see me.
Oh,
I can't
God.
I cannot put the video on. It's not allowed. How are you? Anyway,
I'm good. How you doing?
I'm
How's your
fine.
day been?
Thank you. Just driving.
I can
It's
imagine.
okay.
I was in some traffic as well,
Yeah,
coming back home.
no, it is everywhere was tonight. I don't know what's happening, and at the end there is nothing you can see.
I
No
know. I
accident,
know.
nothing. No
Mm.
accident. Anyway, right, where we about now?
Oh, God. It's just I can't see your face. So today I was just saying that today we wanted to talk more about
Yeah, the hormone
um
replacement
so
in menopause.
understanding the different types of
Yeah, yeah,
hormone therapy,
mm,
replacement therapy,
yeah,
and the alternatives that there are. Also,
yeah,
um
yeah,
how
yeah,
menopause also impacts
yeah.
people living with cancer
Mm,
and how they can cope. What are your
yeah.
guidance? What would your guidance be with that?
Yeah.
And also the other thing that I want to talk about is how to embrace this new chapter with a positive outlook, you know. And for me, honestly, is also ensuring that every woman,
Mm,
either now or at some point later,
mm,
you, with the help of your healthcare provider and practitioner, you can chart your own menopause journey plan,
yeah,
so that honestly, perimenopause, menopause, postmenopause, and what hormonal therapies, the lifestyle modification that you will need for your own unique um journey, because also there's that bit, and so also there's also the bit, well,
yeah,
last week or 2 weeks ago, sorry, we talked about some of the um supplements that some people are using, and what's what, and how also, well, that's when I found out that some of the
yeah,
combination of the stuff that I was using was giving me migraine and also
yeah,
increased blood pressure.
yeah,
So it's just every woman intentionally working with their GP, their healthcare professional, to chart their own care plan for menopause, which is really key. Also, apart from the lifestyle modification, also the mental health, the things that women go through, in menopause, is something
yeah,
that
yeah,
we should
yeah,
continuously have conversation
yeah,
around to help women,
yeah.
live well.
It's
So,
basically
um,
the menopause
mhm.
is a hormone deficiency. It's
Yeah,
basically
estrogen,
we
right?
should not
Yes.
be we should not be judging each other if they can't if someone using the hormone. That is what is important.
Mm,
And every women have different symptom of menopause, and they are different from each other. So
mm,
we can't say, oh, I am not taking and I went through menopause without any problem. That's not true. We Any woman with menopause, it goes through one problem or another,
mm-hmm,
but we all don't like to have extra hormone in our body,
mm,
or we have a hormone to take, especially if your whole life you have not taken even one pill of contraception or
uh-huh.
anything else. But at the menopause is different. Unfortunately, it has a lot of impact. As it is saying, basically, when is menopause? Menopause is in the very crucial time. It is in a time when you are partly in the top of your job, you are very experienced, your children are be teenage or going to university, your husband is maybe older than you or your partner, and the demand of life is more and more.
So,
If you have a teenager, you feel that you have to be very strong for them. If you have a university children, you have to be earning money and you're trying to work hard. And this is all. In addition to that, you have menopause and you have low energy, you have
yeah.
low concentration. So you
Mm,
have to think about what is available outside. We talk about lifestyle. Yes, maybe the lifestyle
mm-hmm,
can make 25% of the things. You can be healthy eater, you can
mm-hmm,
be
mm-hmm.
healthy liver, but also we can't be judgmental saying that this
No,
woman
no,
should not take a hormone.
we
We
can't. We
have to be,
can't, because
and each one has a different problem. So we
that's the
have to be
thing.
open minded. We have to be open minded about the hormone, and they are effective and they are bioidentical. So
Yeah.
bioidentical is about look like what our ovary working. So there is a risk, there is a slight small risk of breast cancer increase,
Okay.
but breast cancer, even if you not take, there is 1 in 12 chance people to get breast cancer. So
Okay. So the way it's going to look, I mean, I have a number of questions here that
yeah,
I want you
yeah,
to help us answer.
mm,
I was hoping that the other people would join. I'll try to add them on so that it's
yeah,
not just all on you, but for some
mm,
reason, I haven't seen Dr. Moji, and
mhm,
I.
mhm,
Anyway,
mm,
I'll get started with you.
mhm,
So, Dr. Kazal.
Yeah.
Tell us, can you explain to us different types of HRT that are available and their unique benefits,
Yeah.
please?
The HRT is available is, of course, it is estrogen and progesterone for the women which are taking, which have the uterus, and estrogen alone if they have no uterus and cervix. And also there is also testosterone, which is for libido. It is mostly for libido. It has small side effects, but we have to be aware of that.
So can I ask quickly before you go on?
Mm,
So with
mm.
HRT, so is there one that has all three hormones, or
No.
is just that? Okay.
Yes, there is one tablet, one type of tablet. It has three of them. But
Ah,
unfortunately, the tablet is very specific because slightly increase the risk of clotting. So you have to be very specific who you provide it, because the patient should, the woman should be very fit, very slim, and very no, I mean, have not any too much risk factor, just in case if it is increase the risk of the clotting. Otherwise, you can. Yeah, three of them is in that. Also, there is
okay.
a cream. There is a cream,
Uh-huh.
not a gel. There is a cream also that has three of them. Yes, it is available, and it's quite recently, for last few months, is coming around. There's a cream, but
Right.
in the what is popular and very available is either a patch or a gel, and the patch can be combined and can be also alone, but with a tablet, which is progesterone, but progesterone is only supporting the line of the womb
Okay.
to have reduce the effect of estrogen. And the
Okay.
gel is the estrogen, have to be also supported by the tablet.
Mm,
And
interesting.
each woman have
Mm-hmm.
different type, have you can give and you can advise how much they can use, but they can change from one to another, because there is no one person to be like the other one. You can't just say, oh, I gave you gel, you have to
Right.
use the gel. If it's not good for you, stop it. No, because every person have a different absorption in their body. They may
Okay.
change from one to another.
So okay. So you can change from one to another. But what I
Yeah.
wanted to also ask you is, so um how do you know which one to administer or to give to the patient? Is it just the estrogen one? Is it a combination one? Or how do you know? Is there a test to
It
figure out
it
what they need more of?
depends on what age. If
Ah,
they are completely menopausal, you
okay.
know, you have, especially 1 year, have no period.
Mm-hmm.
Uh,
Mm-hmm.
it's called menopausal,
Yeah.
and in reality, none of them need blood test. Why? Because if they are perimenopausal, the
Mm-hmm.
blood test doesn't give you any choice. And if they are post-menopausal, which they have no period for a year, it is
Yeah.
quite obvious, unless if there are other symptoms. Especially thyroid function is very important to make sure they are not thyroid
So
problem. They have no
so
thyroid problem.
so in perimenopausal, what's generally given? What's
Um,
what's
we
prescribed?
give them to have a period. We give them
They
to have a period. Yeah, like a withdrawal bleed, but they call it period, but it's not a period. It's a artificial period, which is withdrawal bleed. So it's the same. You can give a gel and a tablet, or you can give a patch and a tablet.
so
But they have to
so
have a
a gel
period.
and a tablet. So that means what? Which ones is it that they have to have in perimenopause? Perimenopause. Because
It's a gel and a tablet, but the tablet has to be taken 2 week on, 2 week off. Then they have a period. But
so
the
how
gel is
which
continuous.
hormones are
It's
those? Which ones?
estrogen is a gel,
Okay.
and a tablet is progesterone. Or they can have a patch which contain both.
Okay.
in a first 2 week and contain one of them in the second 2 week or whatever is with the patches it, and they can have a period.
Right.
But the limit of the patch, the one which is they can use it twice a week, and they have both hormone in 2 weeks of them, and estrogen in 1 week of them. That is only 50 milligram, and some perimenopausal they may need more, so you have to give them again a patch and a tablet 2 week on 2 week off, so just like how we gave the gel. But the tablet is not for perimenopausal. The other tablet which I was talking about, they are all in one.
No, but
Right. Oh, finally, look who I got here. I got Charlotte here. Okay. Thank you. Thank you for joining us.
I do apologize. I have to use my husband's Instagram. I'm not a social media person. I do apologize.
We know. It's okay. We know. All you medical people, you give me problems when you're trying to join the social media.
I do apologize.
Dr.
You're
Moji,
working with an
you
old
are
lady.
late.
Okay. What would you like me to?
Thank you for joining me. Good evening. I've got
Good
Dr.
evening.
Omar on there. I've got Dr. Omar, but she's not putting on a video only because she's in traffic. She's in the car trying to get home. But so our video is not on. But I've got with me also Shola, Taiwo, and also I got Dr. Moji Ademite. So tonight we're talking about embracing menopause journey with confidence. So we're talking about this because women in the hub wanted to discuss this further after 2 weeks ago when we had this conversation. So which is, and I was saying to earlier on that, look, for every woman, it is important that each woman, with the help of their GP or their healthcare professional, start their own menopause care plan. It is important, and honestly, we have to be intentional about it. And so Dr. Omar was telling us about some of the HTR, the various types that there are, and the alternatives. So that's how we've started this. And so thank you and welcome. So Dr. Omar, this one will be for you quickly to the second question. So what are the risks associated with HRT?
The risk, basically, if you use it sensibly and use it in the right way, in the right time, the only risk, as I said, basically the risk of breast cancer in a general population is 14 per 1,000.
14 per 1,000.
Women, 1,000 women have no any HRT. 14 of them still they get breast cancer. But with HRT increased to 19 per 1,000. 19. It means 5 in 1,000 increase. It means 1 in 200 increase. But of course, breast cancer is not just about the hormone, about the genetic predisposition, family history. If their family have a lot of strong family history, it means their mother, their sister, and especially if they have a below age of 50. If they had a breast cancer below age of 50, it is quite familiar. And BRCA gene, if they have a BRCA gene, those things which they have the gene which is positive for breast cancer and other cancer also involved. So you have. So when you take a history, you have to be also. It's not only about menopause. It's about also. It's not only about the symptom of menopause. You have to take a very strong family history as well as if they are perimenopausal. How is their period? Because maybe something else is involved and we don't know.
Okay.
You have to take a full history. You have to do good examination just in case if it is not related to perimenopause, something else is going on. And that is why these symptoms is rising up now. So it's not only we giving the hormone, we have to do a lot of other things as well as family history. So this is only risk, to be honest.
Okay. And these are some of the things that women need to consider when they're deciding if
Yes.
they
Yeah.
want to go on HRT or not.
Yeah.
Yeah.
And don't miss the mammogram, which started from age of 50. And every 3 years, don't miss it. If you have a letter, or if you can't, or call them and they can change the date for you, as well as the examination of the breast when you are in a shower
Mm-hmm.
is very, very important. Before even having anything, it's better to be examined. And but by history and by audit, they found out the women they take HRT, they are more aware of examination of themselves. And even if they develop cancer, they detect it earlier because they are always aware that they have to check themselves.
Right. Interesting. Okay. Thank you for that, Dr. Moji. I was going to ask you, so because Dr. Ma mentioned when we were trying to kind of go through how you decide who when women decide when if they want HRT or not. So you being a general practitioner, I mean, how do you help your patient with that decision? What are the things that you will generally consider? What are the things that you guide and help your patients to understand before making that decision?
Sorry, I can hear a lot of echoing, so I'm still listening to what you're saying. I don't know, it's echoing back to me.
Oh, really? But did
Yeah,
you hear the question?
yeah, I did.
Okay.
Yeah, so what we would usually do is obviously when the woman first presents with the symptoms she has, what we normally try and make women understand, because a lot of the time, once they come in, they come in saying, I have these symptoms, I want HRT. We try to explain to them that, menopausal symptoms are, fortunately or unfortunately, symptoms of so many other things. So it's important that, you're careful that you're not making an assumption
Okay.
when it could be something else. So the first thing we would obviously ask is what they know about HRT, what they know about the menopause, try and give that education
Right.
first. Arrange blood tests initially to rule
Okay.
out other things. So say, for example, Ms. Oman mentioned something about thyroid. So those are one of the things we would do.
Right.
Make sure they're not anemic, they don't have thyroid problems, they don't have diabetes. So we would do that initial screening just to be sure. Because if a woman is, for example, says, her heart is beating fast, or she's having palpitations or having hot sweats, that could well be a thyroid problem. So rather than throw HRT at them without making any checks, those would be the first thing. But in that time of doing those tests and waiting, we give them information about HRT,
Right.
ensure they understand what it is.
Whilst waiting for the blood test.
Yes, they know what types are available. Is it tablet? Is it gel? Is it pack? So that when they come back, they have all of these things and we can make a decision. Obviously, if we have women who have, complex medical
Yeah,
histories, maybe
I
they've
was
had
thinking about
breast
that.
cancer, they've had blood clots, they've had, gynae issues, then those would be the ones who would probably signpost to Ms. Omar and her team to see.
Right. Interesting. Amazing. Amazing. Thank you. Thank you for that. So okay, so you said those kind of ones that are not straightforward, you then send them to
Yeah.
a gynecologist. Okay, got you. Because as you were speaking, that was what was coming to mind to say, okay, even after you've done all of these tests, what if, okay, someone's got other underlying stuff, and it could still be that as well as the
Oh,
menopause.
yeah,
So
absolutely.
yeah.
Of course.
So I
Yeah.
mean, how are they helped to ensure that these symptoms, or whatever it is that they're dealing with, is addressed, apart from whatever underlying stuff is going on. So thank you for that. Shola is also a professional, but I know that your area of specialty is different. But what I wanted you to bring to the table is your own personal experience. I'm going to share my own experience too. I cash out because this menopause thing, 1 minute, and I tell anybody, honestly, it is important for your own good to have a journal and be writing these things down, because I talk for myself. When I then go to the GP, half of the time I've forgotten some of those symptoms, and it's really key that for the doctor, the GP, to help you, or whoever is helping you is gynecologist, they know all of your combination of things that's going on, for you. So what was your combination of stuff, and how did you deal with it when you started having these symptoms, and which symptoms are the most severe ones for you?
Oh, well, my journey kind of started around 20. I suppose my journey started slightly earlier, but I didn't recognize it until 2022. This is post-COVID.
Right.
So I'm a specialist nurse, and I look after sickle patients. So during COVID, it was quite high demand, and I'm a manager as well. So it was quite high demand, teaching, running meeting, organizing meetings, highly leveled meetings, and I was having a lot of brain fog. But prior to that, I was having night sweats, hot flushes. That was just it was
Mm-hmm.
unbearable. And then I approached my GP, and because I'm a nurse, so I'm quite proactive. I did my own blood test at the hospital. I did everything, and I presented it to the GP. And so the GP couldn't come up with it, and because it was so unbearable for me, I
Mm-hmm.
said, I think this is what it is. And she suggested I should, she gave me all the options: the patch, the gel, something, and the pill. I think I started on the pill. I can't remember now. And within 3 months, it was like as if I was a superwoman. Everything was okay. I was working. I had no hot sweats, no
Oh, wow.
nothing at all. But unfortunately, less than a year later, the symptoms came back 100 times worse. So I had brain
So
fog.
did you?
I had the night sweat.
So sorry. Did you stop using the patch and the tablets, or what happened?
I think I used the tablet first, then I moved on to 50 micrograms of the patch. I actually wanted to do, no, I started on 50 micrograms of the patch, and
Mm-hmm.
it didn't work. No, I go back. I started on the tablet, then I moved on to a patch. When the symptoms were really, really bad,
Mm-hmm.
and then I started having more symptoms like frequent urinary. I had palpitations. I've been organizing a conference, and I've been having palpitations and shortness of breath.
Mm-hmm.
And luckily for me, at my workplace, there's so many range of symptoms. You have headaches, migraines, it's scratchiness, itchiness.
Mm-hmm.
Sometimes it's slightly dizzy. Oh, I have a crib sheet that I used to use. I got from work. So they were doing a pilot menopause clinic at where I work.
Okay.
So I went to the seminar,
Mm-hmm.
and then I requested for a review from one of the
Mm-hmm.
consultants there,
Right.
and he asked me to fill out a crib sheet, which I did.
Mm-hmm.
And she said, "Okay, this is what I suggest your GP should do. You should put you on a pack." That's when I started on 50 micrograms.
Okay.
Unfortunately,
Uh,
um, it helped a bit,
okay.
and then it got worse. It got worse. I think it got worse last year,
Right.
where
Hold that thought, because I want to ask these two doctors what exactly is the next step for that kind of thing, because, well, like you, I didn't recognize what it was. Because I will go up the stairs from the tube station. I was working in the city, and I'm like, why am I out of breath? This, you know. Anyway, but what I've just picked out is you just said after how long now the thing wasn't working again. So, Dr. Omar, can you help? What has
Yeah.
happened? what
As I said,
readjustment is required?
as I said before, sometimes the absorption is in the beginning it will be very good, and
Okay.
then start to be lacking. And I do estimate the serum, the estradiol, which is the estrogen,
Mm.
and see if it is high or low, because the high level also cause the same symptom as menopause and worse. Or if it is low, then we increase the dose, because for a while it's been absorbed and it is okay, but maybe not enough. So, but that's why there is a grade of the patch, 25, 50, 75,
Right.
100. Yeah.
Right.
So, and
So,
if it is high, we tell them to stop for a while, because sometimes it is a highly absorption.
oh,
If they are not still enough for increasing the pad, then we change it to gel, because
Okay.
the site of absorption in every woman is different. So that is, we have to play around. It's not like one session
yeah.
and
So,
go home and
oh,
use this.
mm.
It has to be reviewed every now and
So
then,
how
and what
often
symptoms.
is that review? How often what's the
It depends
guidance?
on the women
Okay.
themselves. It depends on the women. In the first 3-4 months, everything is possible. Can be bleeding, can be the symptom not go. We tell them to wait after 4 months. If you don't see them and they are happy with it, but up to 6 months is fine. But after 6 months, they need a review. And if they okay, carry on. If not okay, then you are playing around it. Sometimes even they come back and they say, oh, it is too much. I cut it down from 50 to 25. That's fine, because there is still some estrogen in the body up to age of 60 from adrenal gland, because there's testosterone, and everyone is different.
Okay.
So as I said, so that is why we change it.
All right.
It's very difficult to say you have to have this. No,
All right.
you can change it from one to
Thank
another. Yeah.
you. Thank you for clarifying that. So, Shola, what have you done?
Yeah, so I think I would say February of last year, it came back again and it got really bad. So I think if I said a crib sheet of about 50 symptoms, I must have had about 35 symptoms.
Mm.
And so I think some of the symptoms we tend not to talk about. So it could be about libido. That was affected, and I think sometimes we focus on ourselves a lot and not realize that it will affect your marriages a lot. And I know I talk a lot, and I talk with my husband about everything and anything. So that's something we've had to talk about. I think talking about the negative part about it and how it affects your mental health. For me, I historically had gynae issue, fertility issues. And then when I got to the point of me being menopausal, I was hoping that I would have no symptoms at all. At all. I was obviously dreaming. And then to have a historical issue of fertility, gynae issues, it made me, I won't say depressed. It made me angry. At some point, if I'm being honest, I'd be angry with God, because I thought that from the moment I was my first period to moments where I am now, I'm still having bad periods. I'm still having to. If I'm on an increased dose now, 75 the patch,
Okay.
and I can see the symptoms coming back again. I know when I was reviewed a few months ago, I was told that I need to increase my estrogen, but you get tired of it,
Okay.
because like you put every twice a week, and you take the tablet for breakthrough bleed, and you have painful period for the breakthrough bleed. When will it end? See, we don't talk about the mental health. We just have to
I
carry
know.
on.
I hear you honestly, and I hear you loud and clear. And we will come to that. We'll still have a bit of time. We'll come to that. But I also wanted to just give Dr. Moji an opportunity to also expand on this kind of cases. Have you had one? Because honestly, I hear what you're saying when you have said that if it's people who've had to have other underlying issue or gynae issue, you probably just send them back to the gynecologist and not let it be a thing that the GP deals with. So have you had, like in the case of Shola, after a while now, she's needing more estrogen, and increasing her dose for patch or whatever it is. How do you mitigate that? How do you handle that? Or have you had situations that you can share that would be useful for women to hear tonight? You're on mute. You are on mute, Dr. Mauje.
Yeah, I was saying, I suppose the good thing about the menopause is every woman is different. So you can really tailor, what you're doing to that individual. There's certain things to guide you, but, you just have to look at the person in front of you. Yes, I mean, we deal with menopause a lot. And I mean, from my experience, in fact, I think I'm not seeing as many as I used to in the last, say, maybe 2, 3 years, when there was that whole, thing about the menopause. A lot of women were really coming up to go on HRT. And, you will see women that come, and once you explain to them sort of what they're going through, they'll say, okay, well, I'm happy to go and see how I get on. While some will come straight away and say, look, I can't cope with this, I need something. So it's a discussion to be had. There's nothing.
Individual.
And yes, yeah. And the idea behind HRT is you're using the lowest possible dose that will control the woman's symptom, which is why you start off on low doses, and it's only increased if your symptoms are not controlled. So yes, if they need more estrogen, yes, we'll increase the patch, or say instead of using 2 measures of the gel, use 3 or 4. So it depends. Or we give them a low dose tablets, and if that doesn't work, we can increase it. So it's very individual. And some will come back and say, I've thought about it, I've started the tablet, but I want to stop it. And that's okay.
Right.
So the woman is the driving, she's the driver of really, most of what happens. So the only people that will really have to go and see Ms. Omar are those ones, like I was saying, if they're complicated. Say you have women who have had breast cancer and have had treatment.
Okay, so
but they have
talk about
menopausal
that.
symptoms.
Okay, yeah.
They have menopausal symptoms.
Right.
They're not coping. It's affecting their life. It's like Shola said, it's affecting their marriage. It's affecting their work. What do you do? So in those kind of cases, because they have an underlying issue, it's not that they can't have it, but in that case, we would defer to a gynecologist or a breast cancer surgeon to give us advice.
On how to go.
There are women that have had blood clots, in the past, or have had mini strokes. What do you do with them? You would have to seek advice in those cases.
Okay, all right. Thank you so much for that. So Dr. Omar, once a patient's being referred to you because of underlying issues, how also do you then engage, especially someone who's living with cancer or who's had cancer maybe and then remission or whatever situation it is? How do you help?
Patient with cancer is depend on what is the cancer, and what is the cancer dependent on their hormone dependent, especially breast cancer. Breast cancer with non-hormone dependent, they still can take, they call it triple negative. Those people, they can take HRT because their cancer is non-hormone dependent, but still you cannot guarantee, because this is a long discussion you have to make with your patient, because you can not guarantee that that woman in the future will not have hormone dependent cancer also, but for a time being they have no hormone dependent. Also, you liaise with their oncologist if they are happy. Usually the oncologist is happy if triple negative. Then you can give the HRT. But if they are hormone positive, that is no. But you can't just tell them no and go away. There is nothing you can do. It depends on their symptom. There is a drug which has come out not long time ago for hot flush and sweating. There is, of course, you advise them for osteoporosis, vitamin D and calcium and rich calcium food. For their sleep, you can use a tablet which is either antidepressant or a mild antidepressant for their sleep. Also, lifestyle advice. And there are other things. Sometimes if they are in a long time of remission, they have urinary symptom and vaginal dryness, you still can use some topical estrogen. Although when they look on, I always advise them, when you look on the packet and the leaflet, they say, oh, this is HRT. It is a very mild effect. It's a very small amount, and you can use it for their urinary symptom, for their vaginal dryness, and also moisturizer. So you have to like individually, like a cocktail, what you're going to use for those people. But there are other cancer. For example, patient have colonic cancer. Doesn't make a difference. They can have HRT. But if it is a hormone dependent, any cancer in the body, you should be avoiding it. But you can still help them. Some of the patients come with a back pain, joint pain, fibromyalgia, so they can have like drugs for the pain. For example, very common, I'm sure the GPs, they are more aware of those, is like pregabalin, gabapentin, those pain relief. And most of the people with fibromyalgia have been diagnosed fibromyalgia and they are menopause symptoms. So you have to individualize each one, but any hormone-dependent cancer is no for the HRT.
So
No for HRT.
You just help them manage.
Yeah, we just help them. Yeah. I see nearly, I can say from every day, I can see 5 to 6 menopausal patients. And different type is also the clot. Not only the cancer, you have the clot. It is arterial clot. It is venous clot. Also, you can use the topical one like patch and gel than tablet, because tablet increase the risk of clotting. And if they have a stroke, it's their blood pressure. What was the reason for their stroke? It was a hemorrhage or it was a clot. So it was a heart disease causing the clot. Is that now being treated? So it is all, when they come, we have to go through a long discussion, and we contact sometimes cardiologists or stroke unit to see what was it is. And is they have topical HRT is fine, or as our friend, the specialist nurse, as she said about the sexual and also vaginal dryness, urinary symptom, you can use a topical estrogen in the vagina, but for sexual, it's a testosterone.
Right.
Yeah, that is adding to the HRT, which the GP is not providing it. It has to be specialized again.
So, but is that in addition to HRT?
In addition, the testosterone, you have to check the testosterone also, and then you start giving them. And lots of people, they swear by it, and some, but you have also to discuss the side effect of testosterone, like hair growth in the mustache and chin, slightly baldness, and also may cause, if they use it for a high dose, hoarseness of the voice. But you have to tell them. And some people say, I want it. I don't care about the hair. I will pluck it. I will wax it. I will do anything, but I want, and they have benefit.
Okay. Amazing. Thank you for that. Thank you for that. I wanted to also touch on the impact of menopause on mental health for women and some coping mechanisms. But before then, I also wanted to ask, I mean, Dr. Moji, you can answer this, or even if it's you, Dr. Omar. So, in a case where a woman turns up, she's got all these symptoms, many symptoms that's all pointing to menopause, but she does not want HRT. What's your recommendation? How do you guide that kind of woman?
It's basically depend what are, I know a lot of symptoms. You lifestyle for hot flush and sweating, as I discussed last week. If they want for pain relief, like body ache and things like that, vitamin D and calcium rich food. And also they can use painkiller, as I said, pregabalin, gabapentin, or just paracetamol. If they can't sleep or night, you can give them, for example, amitriptyline, they can sleep. Also, any other symptom like dryness of the vagina, and you can tell them use moisturizer. Not lubricant, moisturizer is good. If they have urinary symptom, because the urinaries, they go around the urologist and they give them and they do cystoscopy, and then it is the dryness because of the estrogen deficiency. You have to explain urinary symptom is that is a reason. You can then give them, if they are not diabetic, as Dr. Moji said, if they are not diabetic and you exclude the diabetes, then you give them some calming down of the bladder. So one by one, and then I think if it has become, they be accepting it and is okay. Yeah, we have patients when they still say there is not any contraindication, but they still don't want to have because they have a fear of cancer.
Okay, so
Yeah.
so thank you for that. So
Mm.
your guidance will be lifestyle modification,
Mm.
and then you
Mm.
a targeted approach to whatever dealing with the
Yeah.
symptoms.
Yeah.
Dr. Moji, you wanted to say something?
Well, yeah. I mean, if they have other symptoms that can be, if they have other symptoms that can be, dealt with, then we'll do that. Sorry, this echoing is really throwing me off.
We can hear you properly. I wonder why you have echo.
I think the echo is from your side because we don't
Oh,
have
We
echo
can
here.
hear you. Yeah, we can hear.
yeah.
Mm. Mm.
Yeah, like Dr. Omar, Miss Omar said, some women that where it's just, vaginal dryness, you target that, urinary symptoms, you target that. But I think, yes. Oh gosh, it's echoing so badly.
Okay. All right. We come back to that. I don't know what's going on there, but we'll
Maybe
come
I
back to
should come out and come back in.
Okay, try that. Try that. Thank you. So I also wanted to talk about mental health, because it's
Mm.
I
Mm.
say
Mm.
is a thing that
Yeah.
we are
Yeah.
going to be intentional
Mm.
to
Mm.
include
Mm.
in our menopause plan,
Yeah.
menopause care.
Yeah. Yeah.
And so,
Mm.
Shola, you were saying earlier on, oh, why are you requesting Shola again?
No, no, sorry. I'm on my husband's phone. That must be. Hold on. I don't know why that's turned on again.
Okay.
Ignore that.
Anyway, so yeah, so you wanted to share a bit of experience around how you deal with it, the mental health issue. I know you talked about foggy brain and work, but I just wanted to just today be able to share information, if we like, knowledge, and how you're dealing with it when it affects whatever symptoms that you have that's affecting, I mean, be affecting your relationship or your partner. And sometimes it's not even just your husband alone, even friends. Somebody says something to you and you behave somehow and they take, yeah, are you all right? It's okay. I only just, and sometimes people don't understand that it's
Yeah.
part of the going on, with
I,
you. So, I mean,
I,
what's your take on it, Shola? And then what kind of support have you found or sought, and what's working for you, basically?
I think one of the biggest symptoms that I historically have, because I have a history of endometriosis, and since I started my perimenopause, it had magnified the pain. At the beginning, I wasn't told that that will happen. So I was told
Oh,
about 2 years ago, about 1 year ago, that my PMS pain will be worse than that. I was quite surprised by that. So if you have endometriosis, you suffer with a lot of pain. So I was so low and down to have pain again. and now I take what do I take? I take naproxen,
Right.
and it doesn't. It's like I'm taking Smarties. It doesn't do anything at all. So that
Marty.
really puts me low. I'm at work. I'm in a high demanding job. So if I'm in pain and I lose, and I don't really have as much bleeding, but the pain is my biggest issue for me, and exhaustion. I would, funny enough, because I'm such an independent woman, I don't really look at it from the point of my mental health. I just begin to realize, talk about it. The libido bit was a shocker for me, because when I was reviewed again by the gynecologist consultant from where I work, because we can tap into that service, they offer that service, and I ticked the box of the libido, and I was thinking, oh wow, and I was thinking, my husband said, well, you have a high libido anyway. I had no desire to have sex. I was not horny. And I didn't realize how it affected my husband. And I think, oh, then when we sat down, we talked about it, and I said, yeah. So we had to talk about it in the way that we felt comfortable with each other, because I think it's quite important to talk about your because menopause is not just you, it's about if it's your partners, your marriage. So I was happy to talk with my husband. We talked about it, and whenever I go through the time, I think mainly around when I go for the tablets, I'm on this progesterone tablet I need to take every 15 days for when I bleed, my last bleed. Then I start to feel a bit low, and I feel the PMS starting to come. I come in, but I'm snappy. I snap at my daughter. I snap at my staff at work. Oh my God, it's horrendous.
So
Oh, I
apart
mean,
from apart from at home support, did you find support elsewhere at work?
I
In the
never.
workplace, did you find support?
I, I've always been a person, I get on with it, but I think there are times when I never seek help. If I'm being honest, it's not a cultural thing. I think because I'm very British, if you want something, you go out and seek it. But because I've always felt that I'm strong, I get on with it. But I'll be honest. I'll be honest to say that sometimes I'm just want to be by myself. I want to be just. I say to God, I just want it over and done with.
Yeah,
That's
I mean,
me. I think
I
because
hear
of
you. I do hear you, but honestly, we underestimate what the support, especially. Well, I speak for myself because at some point I thought I was losing it because I
mm,
forget things, I couldn't cope, and I was thinking I was losing stuff. Like, what's going on? I can't even do my job I've always done for how many years properly, But well, I didn't even know what I was going through, honestly, until I on some job like that, and instead of talking about menopause, I'm like, oh, so some of the things that I'm feeling actually. So, and there will be like a afternoon workshop, like a cafe that you can join during, and it was all virtual, that you can join during the lunch break, for about 20 minutes, and women come. And for me, that helped me a lot. First of all, like, boosted my confidence, like, okay, I'm not crazy, I'm not alone, I'm not going to the end, I'm not getting old, really. That it's not all of this, like, oh, you're old, that's why. No, it's just because this is some of the symptoms, when you're perimenopausal, or when you're postmenopausal and all of that. I'm like, oh, okay. And then even it was in those kind of coffee chats where, and then we start to look, this is how you engage, especially in meetings, because I was forgetting stuff at meetings. I will have presentation and like, what was I saying again?
mm,
It was really hard. So those external support for me was really key, and there was a number that you could call sometimes to just have a chat to see how you even engage with your manager, with your team members and all of that. And that's a great stuff. And if honestly it's something that more and more should happen in the workplace, where
mm,
women can find external support. And and like, we cannot underestimate what you just talked about making sure that our partners, and sometimes even our friends, understand what our situation is. Like, look, oh, because sometimes we have friends who don't understand because they're not there yet, and they're like, why are you snappy? Why are you being nasty or mean and all of that? So it's just about educating and carrying people along, letting people understand. It's not an excuse to misbehave and to dish out nonsense, but is us also just educating, you know, our family,
I
our
just
loved
wanted to
ones.
add something. I think one of the things I would encourage people is not to feel ashamed. I think menopause. I know in the last year, menopause. There's been a lot of awareness about menopause, country-wise, company-wise. But I think we as women, we have this ability to feel ashamed of something that goes wrong with us. I think it's nothing to be ashamed of. Before, I used to feel be embarrassed. This is the beginning to say that what I'm going through is my menopause. Now I just shout and say everything. Oh, sorry, or even when I was doing teaching this afternoon, and I forgot what I was saying. I said just blame it on the brain fog. I do apologize, and they just accept the fact that it happens. So I think like, the learning thing is never to be ashamed of it because it's
Yeah.
just it's nature.
Absolutely, and the more we realize that, and the more we can educate people around us, so that everyone can know that it's okay. It's not like this woman is crazy or she's incompetent, or because those are some of the things that I felt. Then I'll be in meetings and I'm just forgetting stuff mid sentence, and I'm like, wow, this is a meeting where a lot of stakeholders are in here, and I started
Mm.
thinking like, okay, there's something wrong with me. Maybe I'm losing my memory, or well, anyway. So a support network, honestly, is a very important thing. Find a group, find where people are talking about these things, and for me, that's give me courage because after a few of those coffee chats, I then go back into my meetings before we even start. I'm already declaring, if I don't remember what we talked about yesterday, please bear with me. This is my situation, and people are then a bit more empathy. I mean, it's not like you're looking for empathy, but just looking for understanding so that people are not putting you under too much pressure and then you're putting yourself down as well on top of all of the symptoms that you're already going through, So, yeah, it's really important. And Dr. Moji, any last addition for women, regarding how to keep this all of these symptoms and then manage their mental health, whilst going through this journey of menopause?
Yeah, I think it's important to be open about, whatever symptoms you have. Thank goodness this is now, it's in the open now. People are more aware. So it's important that the woman herself is open about what she's feeling, and don't be railroaded into making any decision. The decision you make is the one that's appropriate for you.
You.
And
That's
there's
right.
nothing set in stone. If you make a decision this month and next month you feel, well, things have
That was
changed, I'd like to discuss it again, it's your decision. It's really important that women know that, and empower yourself with information and knowledge. Please
educate
don't
them.
leave
That's right.
yourself in the hands of someone else. You are feeling what you're feeling. So get the knowledge, know what the options are, and then, you can make informed decisions. Very important.
Yeah, it's very, very important. Honestly, it's your journey,
Mm.
it's your body, and so you, with the help and guide of people like
Yeah.
Dr. Omar and Dr. Moji, you can find the best combination of stuff to just make your life
Yeah.
a lot better and comfortable. Really. Um, Dr. Omar, any last word from you?
Um,
And
I asked the specialist nurse said one thing every patient also to know that HRT increase the size of fibroid and also make the endometriosis to recur even if they are quiet after menopause. So you have to highlight that to the patient because a lot of patients they come and say I wouldn't take it if I knew that. So from the beginning, we have to tell them if they have a fibroid or they have endometriosis and also PMT or PMS or PMDD can can be better or can be worse. So they have to know, and they have to be preempted for this discussion, and including in discussion is better to be known to them. Because some women say, if I knew that this is what happened to me, I wouldn't take it. So if you tell them there is a possibility, so they can make their mind.
Yeah.
Okay, I have to go because I'm very hungry.
It's all right, Dr. Omar. I
Thank
hope you're
you.
home now after the long traffic.
Yes, thank you so much. Thank you. Good
Bye,
to see
Miss
you
Emma.
all.
Thank you.
Good
Yeah,
to
thank
see
All
you
right,
you
bye.
for
all.
joining
Bye
us.
bye. Thank
Yeah,
you. Bye
so
bye.
ladies, honestly, Shola, do you have any last things to add? It's really all about the being aware, and also being in a community where you can get the support, you can get the help, the education, information, honestly, to thrive even in this, because it's a natural thing that's happening and must happen. The people are lucky they don't have the symptoms, or they don't have as many. Maybe they don't know they have it, because it took me a long time before I realized what was happening to me. So I've met people who say, oh, I haven't got any symptoms, I'm fine. I'm like, oh, okay, lucky you. You know, so unlike some of us with the night sweats and the hot flushes and the joint pains, you don't want me to start with all of the list, but
That's so true.
But honestly, it's a natural process, and we have to be okay to talk about it and get help. Honestly, get help and talk about it openly and be free, because it's okay. You know, and for me also is educating and helping the partners too, the husband, you know, and the children to get the brunt up. Because I remember one time my son used to say, "You're just angry. Why are you angry?" I'm like,
Yeah.
I'm not angry. You know, so the children getting to just being aware and getting the help. Honestly, getting the help. I mean, there's no one solution for everyone. Find your own pathway, chart your own plan on this journey. But as long as you are living well and you're living a good life, I've had a lot of talk about lifestyle modification. We're trying to modify this lifestyle, you know, to live a better life. But honestly, it is what it is. Let's get help. Let's get the support that we need on this journey. Let's embrace it with positive attitude, because either you like it or not,
We're here. We're in it for years.
Yeah.
Oh, God.
Honestly, thank you so much, ladies, for joining me. And
Thank
also,
you.
women can find useful resources in the British Menopause Society website, also on the NHS UK website. Find information, educate yourself, and help yourself on this journey, and live well and enjoy life and love God. And also, I wanted to say shout out to everyone, honestly, who were raising funds to fiber surgery for women in Africa, and our target was 3.5 billion. Now I think we have 1,150,000 and change. So thank you, everyone who's donated. Thank you as you help us meet our target. We are not there yet, so we're still in the help. Thank you, everyone, and thank you, ladies. Thank you for joining me tonight.
No
Thank
worries.
I hope
Thank you
everyone who's
Thank
for
joined
you.
having
tonight
me.
learned something, and it's been useful information and education tonight. Thank you, everyone who's come, and we'll have
Thank
a lovely
you.
evening. God bless. Thank you. Thank you,
Bye.
Paula.
Have a nice
Thank
Thank you,
you.
evening,
everybody.
everyone.
Bye.
Have a good
Bye.
night. God
You
bless.
too. Bye.
Bye bye.
Bye.